Hello, everybody. My name is Femi Oke. I am going to be your guide, your MC, your moderator for the next 75 minutes for this very special virtual launch of a data collection tool. One of the words that comes to mind is collaborative. You're going to think about this a lot because this data collection tool is an epic example of what collaboration can do. 3 WHO departments are involved, plus partnerships, plus expert panels, committees, or to make this data collection tool happen. It was launched on February the 1st. It was published, the manual and the workbook was published on February the 1st. You can go online and see it right now. But today we're going to tell you a little bit more about it and why it is important. So the next 75 minutes or 73 minutes now, we have interpretation available. If you go to the bottom of your data dashboard, you will find a little globe there. Click on that and you will find options in English, French, and Spanish so that you can participate in this entire webinar in either French or Spanish or English. So I would like to get started with the Deputy Director General of the WHO, Dr. Zsuzsanna Jakab.
Welcome, colleagues and partners. I am pleased to provide this video message for the launch today of WHO's step-by-step manual on inequality monitoring in sexual, reproductive, maternal, newborn, child, and adolescent health. Health inequities are avoidable and unfair, but health inequities are also remediable. All countries can and must do more to ensure their health system is equitable with universal health coverage of quality care. We are at a critical time when all of us need to act and make individual and collective efforts to ensure health systems advance health equity. Health equity means that healthcare does not vary in coverage and quality based on geography, depending on where people are located, or based on personal characteristics such as race, ethnicity, gender, or socioeconomic status. Inequities in sexual, reproductive, maternal, newborn, child, and adolescent health throughout the world mean that 13 population subgroups have systematically worse health outcomes and poorer access to health services. Health equity requires social, public health, and health system interventions. We need sufficient health providers and a health delivery system that is connected and coordinated with community resources and public health. We also need solid health data and accountability. Monitoring inequalities in SRMNCAH is essential to promote equity by collecting, tracking, and comparing data on how subgroups within populations perform on key health indicators. Much work has been done to highlight inequalities in the peer-reviewed literature. However, practical tools about the process of inequality monitoring for SRMNCAH are lacking. This is why WHO has decided to develop a new manual to support countries to monitor health inequalities. Today, WHO is delighted to launch the step-by-step inequality monitoring in SRMNCAH. This manual is a practical introductory level guide to strengthen and build capacity for inequality monitoring in SRMNCAH. It can assist regions, countries, districts, and other jurisdictions to regularly monitor SRMNCAH inequalities and promote the integration of the results of monitoring as an evidence base for equity-oriented national and subnational programming. The objective of this manual is to support national SRMNCAH program managers who are involved in monitoring and evaluation efforts. Sections of the manual will be useful to strengthen the capacity for the interpretation and use of inequality data by other interested stakeholders, such as district managers. The wider involvement of affected populations, civil society groups, and multi-sectoral stakeholders in aspects of the monitoring processes is emphasized in the manual. Given these components, the release of this manual should be of interest to all parties mentioned above. Addressing inequities in SRMNCAH is an important part of WHO's mandate and central to achieving universal health coverage, protecting human rights, advancing gender equality, combating discrimination, and improving social determinants of health. We will continue to work towards this goal. I am encouraged because every day, people in every country are working to make a difference, to create more equitable health systems, to achieve greater health equity. I thank you for your work and ask that we continue to work to progress for universal coverage of healthcare with quality.
So, in the next 70 minutes, let me outline what we're going to do together. Greetings, everybody. So good to see so many of you in the chat and the comment section. You are all very welcome. And I will be looking out, as will the team, for your comments and questions. Do our best. Either we will actually answer them in the comments or the Q&A section, or I might, if you can be quite brief, bring your questions, your thoughts into our webinar virtual launch. So, what will happen? We are going to look at the inequities that exist in SRMNCAH. What is the current state of play? We'll be looking at this new step-by-step manual, unpacking it, highlights. There's also a companion workbook as well. I know you can see the links right there on the side in the comment section, so you won't even have to search. You can look along as well as the presentations is happening, as long as the presentations are happening. And then we have some experts who are from outside of the WHO, looking at how they could use and will use the manual and the workbook. So that is our plan for the rest of this webinar. If you have a look at the acknowledgements page, you're already on the manual. Well, congratulations. Thank you for that. There are 2 pages of acknowledgements. It takes a team to make this entire step-by-step manual happen. And on those 2 pages, you will find 2 names from the coordinating team, Dr. Theresa Diaz and Dr. Christina Pallitto. They're going to take us through the next 15 minutes of our webinar. So good to see you, Theresa and Christina. Theresa, over to you.
Thank you very much. Today, I'm going to be speaking about SRMNCAH inequities. What do we know? I will speak first, and then I'll turn it over to Christina. Next. So I'm going to first talk about a conceptual framework, then global monitoring of SRMNCAH and relevant data sources, examples of SRMNCAH inequality, and what we don't know. Next slide. So I want to make sure that we are all on the same page. So let's first go through the definitions here. Health inequality is a measured difference in health between population subgroups, and is one metric used to assess health equity. And health equity is the absence of unjust, unfair, and avoidable or remediable health inequalities. And if you look at this framework, which was developed for maternal health, you can see there are a lot of factors that are associated with health equity and inequities. There's structural determinants such as governance and policies, culture and social values. There's intermediate determinants such as health services, community context. There's family and peer influences. And then there's individual attributes such as age or education. And all of that together addresses or is relevant for health equity. And we are going to be discussing today mostly about monitoring health inequality. Next slide. Oh, I know this looks like a lot, but this is all the initiatives in maternal and newborn health alone since 1970 to 2020. And the key thing is it's been a ton of initiatives to trying to do a good job to make for better maternal and newborn health. But all these initiatives have something in common. They ask you to address health inequities, and they ask for monitoring of health inequalities. Next. So we do have data that's already available to us to look at health inequalities in this area. We have the HEAT and Global Health Observatory Health Equity Monitor of the World Health Organization that has 6 inequality dimensions in over 115 countries. We have the Demographic Health Survey Program Stack Compiler that has 4 inequality dimensions in about 90 countries. We have the International Center for Equity and Health in Pallitto that has 4 inequality dimensions for 111 low and middle income countries, and is one of the centers that has done most of the analyses on health inequalities in sexual, reproductive, maternal, newborn, child, adolescent health and nutrition. And then we have Countdown to 2030 and UNICEF Equity Profiles, which provide equity profile for 139 countries in the world. Next. So within countries, there are inequalities by place of residence, education, and wealth and quintile. So here are some examples. Next. So this is looking at the percent coverage by residents for child treatments and pneumonia symptoms. And residents is green for rural and blue for urban. And what you see is that there are large inequalities in some countries. There's middle inequalities in a set of countries, and there's smaller inequalities in another set of countries. And always, or for the most part, the rural population has a lower coverage of child treatment for pneumonia than does the urban. Next. Now, this is looking at education-based inequality in child treatment for diarrhea using oral rehydration solution. And in this one, the orange is the no education, I have blocking here. The purple is primary school and the green is secondary school. And again, you have the same thing. Some countries with large inequalities, some with middle, and some with smaller inequalities. And always those with lower education having less coverage of this type of treatment. Next. And this is looking at wealth-based inequalities in skilled care at birth. And this is looking at different wealth quintiles with the poorest in this darker purple and the wealthiest in green. Again, you see the same pattern. Some countries with large inequalities, some with middle, some with small, with the poorest having the lowest coverage for skilled care at birth. And now I'm going to turn it over to Christina.
Thank you, Theresa. So for sexual reproductive health, we see some similar patterns for many of these dimensions of inequality that we saw in some of the previous slides. In this example, the authors looked at modern contraceptive use among women in 11 countries, and they show clearly that there is an association with wealth, with education, and with age, with women of higher wealth, higher education, and older women more likely to use modern contraception. We also noted improvements in access to modern contraceptives over time, but when they looked at unmet need, they found that that remained quite high, especially in some groups. And these were adolescents, migrants, urban poor, refugees, and women in the postpartum period. Now, in the next slide, we see a different example. This is cesarean section, and this is a unique situation. In this analysis, you see that there's a subgroup of countries that are being compared, and there's wide variation across countries in rates of C-section, but also within countries. So what we see here is this blue horizontal line represents the expected rates of C-section that we would expect to see in a range of settings. There's no ideal amount, but this is what we would expect. Anything below that means that women are not having access to emergency obstetric care. And above that means that there are medically unnecessary C-sections happening. So we do see a pattern in many of these countries where wealthy women are getting medically non-indicated cesarean sections, and that's for a range of reasons. And we also see that a lot of poor women are not getting the life-saving intervention that is needed. Next slide, please. So laws and policies and reproductive rights are very much linked with sexual reproductive health. And in this example, we see how the legal restrictiveness of abortion is very much related to the safety of the abortion. So we can see 3 columns here with countries that have the least restrictive laws for abortion, ones that are moderately restrictive, and those that are severely restrictive. And we see clearly that in severely restrictive countries, there's more unsafe abortion happening. Now, in another analysis not shown here, we know that within countries, when women are having abortions, it tends to, even in countries where abortion is not legal, women still seek abortions. And wealthy women tend to find safer options, and poor women tend to have the unsafe abortions. Next slide, please. So there are some experiences that women may have that can be associated with gender inequality and other forms of inequality. And these in turn can increase the risk of sexual reproductive health and maternal and child health, morbidity and mortality. For example, violence against women, female genital mutilation, child marriage, disrespect and abuse during childbirth, and forced sterilization. These are all essentially markers of inequality. And there have been a lot of analyses that have looked at what are some of the dimensions of inequality that may increase risk for these experiences. And likewise, there are a lot of analyses that show how these experiences can thereby increase risk of a range of sexual reproductive, maternal, newborn child, adolescent health issues. There are some measurement options within the Demographic and Health Survey, as well as the Multiple Indicator Cluster Survey. So there are options for doing this kind of disaggregation and going more in depth than that. Next slide, please. So before concluding, I want to take us back to the slide that Theresa showed us earlier in the presentation. And again, there's a large body of literature, many analyses done looking at the structural determinants of inequalities and the intermediary determinants and how those have an impact on sexual reproductive health and maternal child health. So for example, we saw the example of laws and policies related to abortion. There are other laws and policies that relate to other aspects of reproductive health, sexual reproductive health. This could be comprehensive sexuality education. This could be around adolescent sexual reproductive health, whether practices like female genital mutilation and child marriage are prohibited. What are the policies around contraceptive use, for example? We also saw some examples of how women's status and gender norms can impact health, and also particularly around education levels. We know that women's secondary education is closely linked with improved outcomes for maternal health, for child health, and overall for women's health and well-being. At the intermediary level, these are in fact within the pathway between the dimensions of inequality and the sexual reproductive health outcomes. So we see that availability, access, quality of services are very much linked with health outcomes. And at a family level, we know that autonomy and decision-making, whether that's around fertility choices and other decision-making, can be very much linked with maternal health outcomes, with sexual reproductive health outcomes. And this can also affect health-seeking behavior as well. So next slide, just to summarize, we know a lot, but there is a lack of data on some dimensions of inequality. And this may be because of lack of adequate or standardized measurement for some of these concepts. It's maybe difficult concepts to measure, or it may be that certain populations are difficult to reach with some of the measurement that has been done previously. These include race or ethnicity, sexual orientation, gender identity, populations that are internally displaced, refugees, migrants, adolescents and young people, persons with disabilities, data from at a subnational level that relates to district or community levels is often missing, and institutionalized populations, including those in prison. We also have some measurement around service-related indicators, but there is actually little data around the availability of services and treatment in a standardized way, quality of services, equity and dignity in services, and uptake of services. In addition, we have some emerging data on the impact of COVID-19 pandemic on inequalities, and conversely, how have certain groups been more likely to have severe outcomes from COVID, but there's still a lot more to learn around that as well. So the next and final slide, please. So to sum up, despite the gaps in general for sexual, reproductive, maternal, newborn, child, and adolescent health, we do have a great deal of information on inequalities. However, most of those analyses have been done by global institutions, by academic institutions or national statistics offices, and they have not necessarily been used to feed into programmatic kind of changes. So what we need are simple and practical tools for monitoring inequalities that can be used by frontline healthcare workers who may be capturing some of this data, and by anyone who's involved in monitoring and evaluation and program planning. So I'll end there and I'll hand over to you, Femi. Thank you so much.
Thank you, Christina. Thank you, Theresa. I have some instant feedback for you. Are you ready for it? Yep. All right. Unmute yourself, Christina and yes. Theresa, so that we can hear you. I see the nod. This is what Indira says. Great points raised. Will the slides be available after the session?
Yes.
I feel that was an instant spontaneous response there. Indira, yes. So we will work out how to do that for you. So much effort went into the slides and in curating them for you. I know that Christina and Theresa will be so delighted that you want to see them again. So yes, we will make that happen. Thank you, Christina and Theresa. Thank you so much. All right. If you've just joined us, welcome. Great to see you. Great to have so many people who are involved in the SRMNCAH community. Great to have you here. I see you all your greetings from around the world. I should also tell you on your dashboard, if you see the little globe there, we have interpretation in French and Spanish as well. If you scroll up through the comment section, you will see two links. One is for the accompanying workbook that goes with this SRMNCAH inequity monitoring tool. The other one is for the actual step-by-step manual that you can see there, and you can see it as we actually have this webinar. So both of those are available to you, or you can do this, go to who.int/publications. And if you look on February the 1st, you will find both of those publications. They have just been published. So who is responsible for conceptualizing the step-by-step manual and the workbook? Who came up with the idea, put it into this manual form and help that happen? Well, one of these people you've met already in the comment section, that is Nicole Bergen. Nicole is there. If you've got questions, I know Nicole will be answering them. And then also, about to appear on our webinar, Dr. Hosseinpoor, also responsible for conceptualizing the step-by-step manual. And what I'm going to ask Dr. Hosseinpoor to do is to take us through the highlights. Tell us about the manual, the workbook. Where should we start, Dr. Hosseinpoor? Over to you.
Thanks very much, Femi. Hello, everyone. I'm delighted to present to you these two new resources that just being launched, step-by-step manual and the companion workbook. So what I'm going to do is that to provide you with the background and the development of these resources, and also an overview of the components and content of each resource. The development of these two resources is guided by a vision for good health and well-being for all through more equitable SRMNCAH intervention, access, and use. Regular inequality monitoring in this area by stakeholders at global, regional, national, and subnational levels are really a critical input for evidence-based decision-making and equity-oriented programming in SRMNCAH. The main goal of this development is to help people in countries who are involved in the monitoring and evaluation activities to implement regular inequality monitoring in this area that hopefully in turn informs efforts to tackle health inequities. In terms of the scope, the step-by-step manual covers technical guidance and existing best practices. And the companion workbook includes applied exercises that shows us how to do inequality monitoring in countries. So the development of these resources is guided by our previous work on health inequality monitoring. The manual is based on previous publications, namely National Health Inequality Monitoring, which is published in 2017, and Inequality Monitoring in Immunization Manual, published in 2019. The companion workbook and the exercises within the book is actually coming from the exercises that we've been using in the training workshops for health inequality monitoring over past 15 years, and also the e-learning courses that we have developed. Who contributed to this development? So as Femi already mentioned, we had a coordinating group at WHO headquarters consisting of colleagues from 3 departments: data and analytics, maternal, newborn, child and adolescent health and aging, and sexual and reproductive health and research. Health equity monitoring team led the resource development. We also had an external expert review group consisting of 15 people from academic, universities, UN agencies, government and NGOs. They were engaged from the early development of these resources, and they refined the objective and the content of the manual, and also provided comments and feedbacks on different versions of drafts of the manual. And finally, we had many WHO colleagues across the regions and headquarters who also reviewed the manual and provided comments and inputs. Both manual and the workbook are organized around the cycle of health inequality monitoring, which can be broken down into 5 steps: determining the scope of monitoring, obtaining the data, analyzing the data, reporting the results, and knowledge translation. Each of these steps includes several components which are being explored in detail in the manual and the workbook. And now I'm going to give you a quick overview of these steps. So at first, we need to define the scope of monitoring. And for that, there are several sub-steps. The first is to identify and decide which are the population of interest. We're looking at the adolescents, children under 5, women of reproductive age, etc., or a combination of these populations. And then identifying the relevant health indicators that could cover the spectrum of monitoring in this selected population from so many existing SRMNCAH monitoring frameworks. And then we also need to identify what are the relevant dimensions of inequality, by which we mean the categorization of population into subgroups that actually can be used for inequality monitoring. Some of them are commonly used across the globe, like age, sex, education, economic status, place of residence, and subnational region. Some of them are country-specific or context-specific, like migratory status, ethnicity, race, caste. And in that sense, we need to identify that what are those items that we want for inequality monitoring. So after identifying our framework, our scope of monitoring, then of course we need to obtain the data. And we recommend to do the so-called exercise data source mapping. And by which I mean to listing the data resources that exist in a country or in a setting, including household surveys, administrative data, censuses, CRVS data, and then within each identifying which indicators and inequality dimensions that are selected in step 1 are available in these sources. This way we can create a map that actually helps us to see where we have data, enough data for inequality monitoring, and where we're lacking them. And of course, when we're lacking disaggregated data, we are not able to move forward to the next step of data analysis. So we need to collect the data, the required data. Or we can go back one step to step 1 and amend the scope of monitoring by replacing the indicators and the dimensions for which we have the data. So as you see, the cycle and going from one step to another one is iterative, and we can go back and forth to really find the best fit for our inequality monitoring. Then, having the data, we need to analyze them. And they are two distinctive processes or activity in data analysis. So one is to prepare disaggregated data. So for example, simply, we would like to see and to have skill birth attendance disaggregated by economic status and shown by household wealth quintile, or under 5 mortality disaggregated by place of residence and shown for urban and rural areas separately. And also we would like to calculate summary measures of inequality. What are they? As their name appears to be, they summarize inequality in one single number. So we know and use some of them very commonly, the ratio and the difference. So for example, we normally use the difference in a skill birth attendance between the poorest and richest quintile, or urban-rural ratio of under 5 mortality. Each of them, summary measures and disaggregated data, have their own advantages and are complementary to each other. Disaggregated data provide us the pattern of inequality in a population and show us the health situation in the disadvantaged group. Summary measures of inequality, on the other hand, they can be used for assessing inequality in a very quantitative way, they provide us one number. So it's easy then to compare inequality over time and see how is it changed over time, or across different settings, across provinces in a country, or looking at within country inequality across countries to look at, to have global monitoring. The next step is, of course, reporting the results, and there are several considerations here. The first part, of course, is to take into account the needs and the technical expertise of the target audience. Most probably, the way we want to report to policymakers and to public is different from the way to report to researchers. We need at minimum to report on latest state of inequality, and data permitting, we would like to see change over time in inequality. Technicality of the report, of course, depends on the target audience. We could have some complex measures of inequality to show more nuances and content of the data in a research paper, but then communicating with policymakers, we want to use very simple, salient messages. And there are different ways to show the results. Always we use text, tables, figures, and maps. Particularly here, maps are quite important to show geographical inequalities. And we highly recommend the use of interactive visualization of data, which actually could convey effective communication with different target audience and involve them interactively with the data. And of course, in some cases, we would like to show further information like confidence intervals, or for example, if you want to show urban-rural inequality in under 5 mortality, it's good also to show the proportion of population living in urban and rural area and how that composition of the population has changed over time. And manual also touches on the last step, knowledge translation, which is the exchange of knowledge by relevant stakeholders. Remembering that the ultimate goal of inequality monitoring is to tackle health inequities. And to do so, the results of inequality monitoring should be available and accessible to all stakeholders and used by them. So to do so, one part that can be done in the process is to come up identifying the priority areas for action. It's also important to note that there are other sources of evidence like quantitative and qualitative research studies that could provide the context and be complementary to the results of inequality monitoring. And as all we know, many other sectors beyond health play an important role in tackling health inequities. So it's important to look at different sort of identifying opportunities for intersectoral collaboration and combine the actions on social determinants of health with the actions within the health sector, like universal health coverage and primary health care. Just to provide you with a bit more of the structure of the manual and the companion workbook, let's have a look at example. So manual provides for each substep a key question and a checklist. So as an example here, for step 1C, the key question is which dimensions of inequality are relevant for monitoring SRMNCAH? And then the users are asked to select the dimensions of inequality that they think are relevant to their context, their country or program. And also to explore if it is appropriate to combine dimensions of inequality together, the so-called double disaggregation. Sometimes we would like first to disaggregate by sex and then let's say by education, or sometimes we want to have double disaggregation of place of residence and economic status to look at what we call urban poor, for example. So all these considerations could be taught at this stage. Respectively, in the companion workbook, they are applied exercises that actually readers and users could fill in the relevant information. For example, for sub-step 1C, there is an interactive template where the users can select the relevant dimensions of inequality and also identify the most disadvantaged and most advantaged subgroup per dimension that is going to be used in the next stage for data analysis. Both manual and the companion workbook now are available in English, and they're going to be translated to other UN languages soon. In addition, we are planning to develop and release an e-learning course on inequality monitoring in SRMNCAH very soon. And there are other resources on health inequality monitoring that two new resources could complement others. So we have a more comprehensive resource, handbook on health inequality monitoring. We also have developed global thematic reports, one of which is actually on a state of inequality in reproductive, maternal, and child health, which was published in 2015, and perhaps sooner or later we need to update the global state again. As Theresa mentioned, we also had one of the largest global databases of disaggregated data, Health Equity Monitor, which covers lots of information about SRMNCAH indicators disaggregated by different dimensions of inequality. Health Equity Monitor also provides interactive visualization of equity country profiles for 115 countries for which we have data. And last but not the least is Health Equity Assessment Toolkit, HEAT and HEAT Plus, which is the software application to assess within country inequalities. And there are two versions of that. Built-in database that includes Health Equity Monitor database and Upload Database Edition that allows users to upload their own inequality data and assess inequality. Thank you so much. So over back to you, Femi.
Thank you, Ahmad. As you were speaking, one of the earliest questions that we got was a really giant one from Abu Ishmael Fashanji. Does the manual cover all aspects of inequality, including access, need, and financial allocation? I know it's a brilliant team. I don't know how you would cover all aspects of inequality, but Ahmad, what would be your brief answer back to Abu?
Yes, so the answer is that basically we should existing frameworks for health indicators. And in the domain of SRMNCAH, there are many. So one of the specificity of the handbook is to show best practices and identify all the existing resources. So in that sense, we identified what are the available frameworks, but also pick up some examples to showcase how inequality monitoring could be done in some specific examples, but that's exactly applicable to the other areas or other spectrum of SRMNCAH.
Okay, all right. Thank you, Ahmad. Thank you so much. I am going to send you to the comment section. Lots of questions, lots of interest. I will let you weigh in with Nicole to help her out. All right, so we're going to move on. In the comment section, you will see, if you're watching attendees, some of the external reviewers of this resource, and they're talking about their experiences, what they learned, and what a positive experience it was, which is really the idea behind our panel, because we wanted to bring together people from different parts of the world with different fields of expertise, but all really underneath the banner of SRMNCAH, to talk about the manual, the workbook, what it means in their field of expertise. We will put up a slide so you can see all of the official titles, but I will greet them warmly by their first names. I know they will allow me to do this. So I will say hello and welcome to Paula, Asha, Anna, Oscar, and Betsy. Paula, please will you introduce yourself to our attendees who are all over the world? Tell them who you are, what you do, so they understand the perspective that you're going to bring to our panel conversation. Hello, Paula.
Hello and greetings to all. It's such a pleasure to be participating in this event. The manual is such an outstanding resource. It's conceptually sound, it's technically sound. It's rare that those qualities go together. And I personally am going to use it. I have worked for many years with the California Department of Public Health on monitoring maternal and infant health in the state of California, where 1 out of every 7 or 8 births in the US occur. I think that my colleagues, both the university-based and Department of Health-based colleagues, are going to be very interested and benefit from looking at the manual, because it gives such a systematic approach focused squarely on monitoring inequalities.
All right, Paula, we're going to hear more from you. I want to actually say hello and greet your co-panelists. Asha, so good to have you. Please introduce yourself to our attendees from all over the world, who you are, what you do, your field of expertise.
Good morning, good afternoon. I'm Asha George. I'm a professor at the School of Public Health at the University of the Western Cape, and I'm delighted to speak to the manual. I work with those in the health system who are trying to make a difference. And so who are on the receiving end of these reports and what should they do? And I'm delighted that the manual has a very strong knowledge translation component. So not just measuring numbers, but actually communicating and spurring action to respond to them. Thank you.
Oh, it's so good to have you here on board. Hello, Anna, welcome. Please introduce yourself to our attendees.
Hi, everyone. My name is Anna Belon. I am a senior research associate with the Center for Health Communities in the School of Public Health, University of Alberta in Canada. And I wanted to acknowledge that I am speaking from Edmonton, and Edmonton is situated on Treaty 6 territory, traditional lands of First Nations and Métis peoples. I would echo the words of Dr. Paula and Dr. Asha about how relevant this report is, and I'm already using this document on my own work with a municipal department of health back in Brazil and also here in Canada. And I think the main strength of this document is exactly what has been said about the knowledge translation component. So it's taking that evidence and help it to put into practice.
Mm-hmm. Anna, how are you already using the manual? It was only published yesterday.
So
very sneaky.
Yeah, so I had the chance to be part of this review. So I think one of the things that Dr. Ahmad was saying about the scope, the data mapping, so that resource was so useful, creating it's just a work list where you can create list all the resources instead of you opening so many web pages and trying to find those data sets and find the information that you need and cross-check. And there it is, this brilliant spreadsheet. You can compile all the information needed. So being sneaky, but very happy to start using it as soon as possible. And I'm sure I'm going to send out this to everyone who is doing the same kind of work that I am.
All right, thank you so much, Anna. Let's meet Oscar. Hello, Oscar. Good to have you here. Please introduce yourself to our attendees.
Hello, Femi, and hello, everybody. Actually, it is an honor, not only a pleasure to be with you today in a company of such an outstanding panelists and presenters. My name is Oscar Mujica. I am originally from Peru, South America, And I work as the regional advisor in social epidemiology and health equity in the Department of Evidence and Intelligence for Action in Health at the Pan American Health Organization for several years, actually a lot. And I am very honored to be a close time collaborator to Ahmad and Ahmad team in this health equity monitoring, starting from with the 2013 Mighty Manual. We have been working also in inequalities, in measuring inequalities, health inequality or social inequalities in health from the 1990s. You know that in our region, our directors have been very vocal about this issue, equity, coming from the most inequitable region of the world. That makes total sense. I will be very happy to share some thoughts on the outstanding manual. Thank you, Femi.
So glad to have you here. And finally, Betsy, welcome. Please introduce yourself to our international audience. Tell them who you are, what you do. Betsy, I'm going to get a take two on you because we see you, but you need to unmute yourself. Go ahead. We don't hear you. Try one more time, Betsy, and then I'll come back. Keep talking. All right, so I don't hear Betsy right now. Betsy, I'm going to try and come back to you. I definitely want to come back to you, but I don't hear you at all. So let me revisit you. Just try one more time, Betsy. All right, okay. All right, so I don't hear Betsy. Try again. I hear something, but not Betsy. All right, Betsy, I'm going to send you backstage. Our team backstage will help you, and they will type to you so that we're not doing this checking the tech during our webinar, but we will definitely have you in this panel. It may be headphones, it may be mute, maybe just reconnect and connect again, that old IT trick. All right, so I want to go back to Paula. Paula, in your work, in the field of your work, where do you feel that the manual is going to be most useful? Where are you so certain that it's such a perfect mixture of concept and a technical source as well?
Okay, well, I realized that I failed to introduce myself initially. I'm Paula Brave.
You were so enthusiastic about the manual, like, don't worry about me. Let's talk about the manual. Go ahead, Paula.
Exactly, so focused on the content.
Yeah.
So I am at the University of California in San Francisco, where I'm founding director of the Center for Health Equity. I want to tell you a story that I think will illustrate why I think the manual is so important. And of course, the story begins once upon a time. And this is now, a couple of decades ago. There were a couple of very powerful men at a global health organization, which will be unnamed, because that's not.
Paula, you spoiled the story already.
Yeah, and they came up with this very clever way of monitoring health inequalities that completely removed the social justice content from the exercise. And one of the things that was very disconcerting was that a number of people that I knew who should have known better sort of jumped on the bandwagon and said, what a cool technique these people had discovered. And it made monitoring so easy because, of course, you don't have to collect information on the dimensions of inequality. And what it taught me was that people were very profoundly unclear about what inequalities, health inequalities are, and what it meant to monitor inequalities. So I am so enthusiastic about this manual, both because it's outstanding and because I think that it can play an important role in making it clear to some new generations of people who'll be involved in monitoring, so that they will not be confused by fancy technical work. And I think that it really, that the concept of that the essential part of monitoring health inequalities, what that is, so that's so much part of the fabric of the manual that I think it will be a protective shield that we will have, so that there will not be a repeat of the sad story that I told you at the beginning.
Thank you. Asha, people have already begun picking up on the idea that you shared about action, that the people who will most benefit from the tool could be listening, watching right now. Can you unpack that a little bit more? The idea of it not just being, oh, it's great, we can download it, it's there, but will it just stay in our inboxes, or what is the action that would happen from this resource?
Thank you.
Thank
you. There is such a huge body of work and a network of people who have refined how we understand inequality and health inequity. And many of them, Paula Braverman and others, the colleagues on the panel, are here. What I really appreciated was that although you saw a lot of graphics, and there are a lot of numbers, but these are not just numbers, there are faces behind those numbers. And they're not, it's faces of people, marginalized groups that have been affected by all kinds of forms of discrimination. And particularly when it comes to sexual and reproductive health, gender discrimination is a powerful inequality that goes beyond just disaggregation by sex. What is striking to me is it's not just the faces of those who are affected, but we also need to remember the faces of those who can make a difference. And what I liked about the manual is that there are sections throughout where they talk about data is very important, but the processes of consultation to start right from the beginning on engaging audiences on scope, acknowledging where, and you already saw a slide on the limitations. Some of the most marginalized populations we struggle to get data on: transgender populations, sex workers, in countries where abortion is illegal, those accessing illegal services. So what I liked is that although the manual is talking about quite mainstream sources of data, it at least acknowledges these dimensions and talks about the importance of contextualizing the information, and then looks at how do you consult people at every step. It's not just at the end when you have the report, but at every step of the process to accompany the way in which you collect data, who you present it to, how you present it to it, so that it actually, for two reasons, not just to have impact, but also, sorry, I have a enthusiastic 2-year-old participant, but also because these are marginalized populations and there is the possibility of recrimination, of people not liking the message. You know, this is contesting power and you're trying to change the status quo. So you have to work with people to, when you deliver the data, to affect change. And that means really looking at what are the solutions they feel they can bring to the table. let me pause there because I think others will have a lot to say on this as well.
A lot of nodding heads. Thank you, Asha. Come back to you. Oscar, you have your very thoughtful face on. You describe this resource as outstanding. As you all know, there were many challenges in measuring the inequities in SRMNCAH. So what makes this resource outstanding? How will it help? How could it help?
Thank you for the question, Femi. It's provocative. Let me start by, again, highlighting and congratulating this truly interdepartmental effort or collaboration within WHO. I think this is exactly what we need. And one of the things that it is related with one of my remarks on the outstanding work. I think that we need to make with this manual and the companion workbook, as well with the previous one, really massive capacity building effort. Massive capacity building effort. Modestly, in PAHO, in the Americas, we have been doing this for years, and also with Ahmad and his team, and in an interdepartmental fashion too, particularly with our Department of Family Health Promotion and Life Course, and especially also with our Latin American Perinatology Center. But also we have been working with other agencies. I can say particularly the Every Woman, Every Child in Latin American Initiative, EWELAC, and more recently with the Robert Wood Johnson Foundation. The capacity building should be doing bottom up, not only top down. So meaning working at the national level with the heads at the national level, but also at the local level. And one of the beauty of this tool is that, and I want to stress this particularly, because this is the way we have been working in the region. One of the beauty is that we can apply this framework, these guidelines, this manual to an eco-social approach of inequalities, meaning that, yeah, we of course favor the data at the individual level or the household level, the survey data. These are the best, of course. These are the best, but they are not readily available in every country. But we do have administrative data, even imperfect, incomplete, outdated, but we do have. And the best way that we have learned actually in the Americas to strengthen the health information system is to strengthen the analytical capacity. And we can strengthen this analytical capacity with this type of manuals. The other thing that I would like to highlight is that because of this manual, we can make a more clear convergence between measuring and monitoring health inequalities or social inequalities in health with the social determinants of health approach. In 2008, since 2008, with this WHO Commission, we learned that the only way to reduce or eliminate unjust inequalities in health is through the action on the social determinants of health. And we still have, I think, an unfinished business in terms of the implementation of that. So in that regard, I think that we can even stress a little bit more this, because that can help, especially step number 5 of our monitoring cycle. Step number 5, which is the knowledge translation. As long as we can make more explicit this link, which is indivisible, between the social determinants of health and on health equity monitoring. Finally, I think it is beautiful also and outstanding because it is clearly a tool that can empower people at the local level. You don't need to be a PhD to do that. Honestly, we don't need that. With all due respect, but we can do that. And this is the way to really strengthen our accountability on the promise of leave no one behind. Because for all the rhetoric mentioned on the Agenda 22, which is beautiful, we still don't have any indicator that measure reduction in inequality. So how can we be accountable of, we are doing efforts to leave no one behind? Mm-hmm. Because of that, I think this is outstanding, Femi. Thanks, sorry.
Oh no, I never want to stop passion in full flow. Speaking of leave no one behind, Betsy, let's pin Betsy on our little collection of panelists, and let's see if we can hear Betsy. Betsy, I'm anticipating hearing you. I'm hoping I'll be able to hear you.
Yeah. Can you hear me?
Yes, and I'm so happy. Hurrah, hurrah. This is so good. See, Leela Varkey says the new inequality is digital inequality. So I do hope we get the final panelists. And as Oscar says, leave no one behind. Betsy, welcome. All right.
Thank
Betsy,
you so much.
Such a build-up, such a long build-up, such drama, Betsy. Now, Betsy, do go ahead, introduce yourself to our audience, tell them who you are, what you do, and the impact that you see this resource having, how you will use it in your work, your field. Betsy, the floor is yours, finally.
Yeah, thank you, Femi, and thank you for the invitation. I'm very honored to be here. I am the regional advisor on child health here in working for the Pan American Health Organization in headquarters in Washington, D.C. And I'm very glad to have this opportunity to talk about this manual. I found it very easy to follow, but when I was reading it, the question that came to my mind is now how to make it happen at the country level. And I think we have to think through how to do it, depending on the context of each country. But I think one of the challenges that we have is to improve the way we make data talk, so that it talks to everybody. It talks to the people, the technical people, the program people who are deciding what intervention and what kind of services we want to improve, but also talks to the managers, to the administrators, those who are deciding where the money goes, how much money is allocated to different areas, where human resources go, what type of human resources we have. And are we going to do something to improve the way we procure our medicines, everything that we need to make services actually happen? I think the challenge that we have is to use this manual. And then when we have the results of the data analysis, we combine the discussions where we discuss the technical part as well as the managerial, the administrative part. And I want to stress something that was mentioned before, is the importance to discuss the results with the local people, with those who are the experts on what are the problems. What is it that I found myself involved when I trying to provide this service? And don't forget also to discuss it with the communities, because they are the ones who know what kind of barriers they have when they try to access our services. And I think the more we understand why we are having these different patterns of inequalities, the better we'll be able to find solutions. Because we know that moving from a wide range of inequalities and get closer to that universal coverage, universal access, and equity, we know that in order to move closer to that final goal, we gotta find local solutions. We need to understand better what's happening at the local level. So I think I'm already thinking in different ways in engaging our colleagues at the national, but also put more emphasis on the local discussions of the data and trying to find solutions. Over.
Hannah, one of the things that I know the coordinating team involved in the resource are so proud of is that there's a lot of sophisticated complicated data that is produced by academic institutions. But this resource can be used by anybody. It's accessible. You don't have to have a work alongside a huge academic institution to get the data for you. It is there for you. I am going to ask you to, almost like we're going to vocalize, you know, the blurb on the back of the book. Like if we were going to write a little blurb on the back of this manual, it's digital, so we're going to perform it in the webinar. What would be your line that you would say? Anna, you have the short straw. You start. It would say, Anna Paula Bellon, and then it would have a quote on our digital manual. What would your quote say, Anna?
I would say the beauty of this manual is exactly the bringing to our attention to explore the possibility to work with and working for the intended communities and the knowledge users. So we were producing data that are meaningful for them so they can take action, then can inform their next steps. I think we needed to think of, and the manual helped us to think of, who are at the decision table and who are left out. So as the manual explains, we needed to engage, to have this dialogue between knowledge users and knowledge producers if we want to move the needle and advance health equity.
All right,
that would
be you've written an essay. Yeah. You've written an essay on the back of the book, but it was a good one. Asha, what would your blurb say about this resource?
An important starting point to spurring action to address inequalities that undermine sexual and reproductive health outcomes. And I say that because it is very accessible, and it explains, it tries to make a lot of routine data analytics and key principles, communicate them in a way that they can be understood, and the importance of those for sexual and reproductive health. It's a starting point because I think in this field, it is evolving so rapidly, particularly when you look at forces of marginalization. So when you look at gender inequalities, how we measure that, there's a lot more it's a field that's constantly changing. But it is a great way to get people beyond academics involved in engaging with data and beginning to use it to affect change. Thank you.
Thank you so much. Paula.
I really like what Asha and Anna Paula have said. But what I would add is without measurement, there is no accountability. And, you know, we can't stop, we're all very clear, you can't stop at measurement. And also to get good measurement, you need the capacity building to be part of it.
Paula, I see that. Yeah, I can actually physically see that in my head, in my imagination. All right, thank you. Betsy, what would your blurb be?
Mine would be, we have enough data. Just put more efforts and use it.
Okay. Asha is laughing her head off. Yeah, we have enough data. And Oscar, the final blurb on this brand new resource.
I have the advantage to have more time to think about it and be fed by your excellent contribution. I would say, my blog would say something like that. Now we have no more excuses to refrain, to use our data to monitor SRMNCAH inequalities in health, to generate evidence and to inform equity-oriented policies. Or as Paula said, brilliant as always, we have our opportunity to be accountable now. Thank you.
Panel, do you know what I hear? The sound that I hear? That is the sound of hundreds of people downloading the manual because of what you just did in the last 20, 25 minutes or so. Thank you. Excellent job. We really appreciate you coming together and helping us really understand the practical use of this resource. Really appreciate you. All right, so we have to wrap up, and we're going to wrap up with Dr. Asma Samra, and she is Assistant Director General. So nice to see you.
Lovely to see you.
And how are you going to wrap us up? That panel did such a great job. Now
You've
they're
done a
handing,
fantastic job as a
handing it over to you. I'm just the glue. I'm not the brains, but the brains did a great job.
Absolutely, yes.
Go ahead.
So colleagues, first of all, thank you so much for joining us today. And a huge thanks to all the panelists for your searing insights and for shining a spotlight on the pernicious inequalities in sexual, reproductive, maternal, newborn, child, and adolescent health that surrounds us. While we've made some progress towards greater equality in health, overall, the progress has been halting and hesitant. It's important to not allow the pandemic to set us back in our quest to uphold the principles of human rights. We know with COVID-19, women, adolescents, children, and newborn continue to be disproportionately bear the brunt of health and economic impact. This guide comes truly at an opportune time. It is built, as we have heard, on immense body of work and is a result of diverse collaboration and contributions from many inspiring colleagues from around the world. Many of you are participating today, so thank you. And also to colleagues from within the organization representing diverse sectors, and thank you for your commitment to this important work. Your diverse perspectives unite us to be impatient. As Oscar just said, we need to be impatient and begin using this manual so that we can truly bring equilibrium to our societies, communities, and economies. Here are my two takeaway messages from today's seminar. One is that health inequality is a measured difference in health between population subgroups. Theresa defined this for us. Here, the operative term is measured difference. And to measure, we need timely, reliable, and disaggregated data and smart insights to prevent, detect, and respond to inequalities. Otherwise, inequalities persist unchecked. At this time, there are significant data gaps which we must fill. We have the Score for Health data technical package that tells us where the gaps are and the tools to close the gaps. And this is in addition to the tools that we have. Second, we have this tool now in our hands to apply in countries at subnational and national levels. The manuals and the workbook are very timely and outstanding, as Paula described, and truly a valuable resource to sharpen health inequality monitoring and manage how we close these gaps. Dr. Tedros, in his last week's message addressed to the executive board, identified 5 priorities and see how health inequalities cuts across those 5 priorities. The first priority is promoting healthy life and well-being and preventing diseases by addressing root causes. And one of the profound root causes is health inequalities. Second of his priority is to reorient health systems towards primary health care as the foundation to achieving universal health coverage. And we all know primary health care prioritizes equity. Third, strengthening pandemic preparedness and response at all levels. And we are seeing just how vaccine inequities are so abound and so important that we track those. Fourth is all cross-cutting themes that will help us close the gaps, how we accelerate progress towards SDGs and the 3 billion targets by using science and innovation, data delivery and digital tools. And what cannot be measured, cannot be understood, cannot be managed. And finally, his fifth priority is to strengthen global health architecture. And with gender equality, equity, and human rights becomes at the core of the global health architecture as we go forward, learning lessons from the pandemic. I would like to leave you with a quote from the WHO Commission on Social Determinants of Health. I quote, "Acknowledging that there is a problem and ensuring that health inequity is measured within countries and globally is a vital platform for action." And this step-by-step manual does that. And finally, I invite you all to scroll, to download this resource and share it widely within your networks. And we look forward to hearing your feedback. As Oscar said, we have no excuse. And thanks to the team led by Ahmad and Theresa and many others to bringing us this really important resource at this time. So we look forward to closing the gap. Thank you very much. Over to you.
Thank you so much, Dr. Asma. Dr. Asma did all of the thank yous, apart from webinar attendees. You were spectacular. The best webinar I have been to all year. Thank you so much for your participation, your enthusiasm, your really interesting questions and curiosity. All right, so many times have we put the link for the workbook and for the manual in the chat. Quickly scroll through if you haven't got that yet. It will also be available eventually in French and Spanish. And if you'd like to share this entire webinar with your colleagues, you can do so by going to the registration link. But for now, thank you for attending. This webinar is now closed.
Thank you.